ultrasound of the wrist and hand. And again, ultrasound is very well suited for examining the wrist and hand because all the structures are very superficial. It's a very quick way of examining the wrist and hand, so it's very cost effective. And particularly in the fingers, we can perform a dynamic examination, so we can flex the fingers to look at how the tendons are moving. We can do passive extension or flexion. So there are many advantages of ultrasound. And we mustn't forget, I mean, my last lecture is going to be on intervention. Ultrasound will also allow us to guide interventional procedures of the hand and wrist and the other joints. So the topics that I'll cover are the technique for examining the hand and wrist. I'll run through the anatomy and the pathology. You can see here an extended field of view image of the finger, and you can see the distal phalanx, the middle phalanx, and the proximal phalanx, and the metacarpal head. And you can notice the flexor tendon, but the flexor tendon has got anisotropy within it. So remember, anisotropy again is a very important artifact that you can encounter when looking at the hand and wrist. You'll notice in a lot of my presentations I use extended field of view imaging in MSK, and most modern ultrasound machines these days will have the ability to do a C-scale or an extended field of view image. And the reason that it's a good thing to do is that it helps you orientate yourself with regard to other structures. And as well as that, one of the complaints of our clinical colleagues is that they prefer MRI because they can see the image and they can understand the image. If you do extended field of view with ultrasound, then it makes the image more understandable for our clinical colleagues, and they'll have more confidence looking at the examination. There are some practical tips that you should use when you perform ultrasound. One is to use lots of jelly, because sometimes with the small structures in the fingers, for example, you'll have poor contact with the structure. So you can see here, this is a finger in cross-section, but I put in a lot of jelly at the sides where the stars are, so that I can have very nice contact with the side of the finger. If you don't have jelly in that area, then you will end up having artifact because of air. This is another very important thing that you can do, is look at both sides. Look left and right, compare both sides. You can see here, this is tubercle in the distal radius. And then finally, the anatomy in this region can be very complex. So, maybe not in front of the patient, but don't forget, you can look up the anatomy books and compare the anatomy and learn ultrasound by doing it that way. Another important thing is to use comparative imaging. So compare your MRI images with your ultrasound, and again, that's a good way to learn. This was the effect of anisotropy. This is something that particularly affects MSK imaging, because we have many structures, such as the ligaments and tendons, which have fibers that are all traveling in the same direction. And unlike structures like the liver or the kidneys, in tendons, all the fibers are traveling in the same direction, so the angle of inclination is very important. And it's important that you don't overcall an abnormality because you are not putting your probe on in the right direction. So the doctors who came to the hands-on session 2 days ago will be familiar with how I like to orientate myself in the wrist. When you're looking at the level of the distal radial ulnar joint, if you put your probe horizontally, you'll see two bones. It's your distal radius and your ulnar. You can see where I put the cross-section on the X-ray. And related to these structures here, with Lister's tubercle as your main anatomical landmark, you have the extensor tendons, and there are 6 different extensor compartments. It's not important to remember all the names of the tendons there. All you need to know is that there are 6 compartments and how you number them and how you can detect which compartment is involved. And Lister's tubercle is important because this separates extensor compartment 2 from extensor compartment 3. So as soon as I've seen Lister's tubercle, I know where I am in the wrist, and then I can start counting. So I can go extensor compartment 2, 3, 4, 5, 6 will be there, and 1 will be down here. But it's just having a way when you put the probe onto the patient that you say, I know where I am, and this is how I'm going to orientate myself. And then as you go distally, you can see I'm comparing the ultrasound image with the X-ray image. And you all know your X-ray anatomy, and you all know that the proximal carpal row has got 3 bones. It's got the scaphoid on one side, the lunate in the middle, and the triquetral on the other side. And it's the same on ultrasound. So you're looking, you see 2 bones. As you go more distally, you see 3 bones. And those 3 bones have the lunate in the middle. And in this position now, you can actually see the position of the scapholunate ligament, and the dorsal aspect of that ligament can be seen. And that's an important structure to be able to identify, because in patients who have a ganglion at the back of their wrist, usually that ganglion arises from the scapholunate ligament. I don't recommend ultrasound for detecting injuries of the scapholunate ligament. I think MRI is the way to do that. And then I look longitudinally, and again I'm thinking of my plain film anatomy. I'm thinking in the middle, when I'm looking on my lateral X-ray, I want to see the distal radius aligning with the lunate and the capitate, and that aligns with the middle metacarpal. So there it is, your anatomy exactly the same as it is an X-ray. So there's no need for you to be lost when you put the probe onto the wrist, thinking, oh, there's so many bones, I don't know which one is which. All you need to do is think of your plain film anatomy and translate that onto your ultrasound image. On the volar aspect, the important structures are the median nerve and the flexor tendons. And you can see the median nerve there that is highlighted. And there's the flexor retinaculum. And you can see the flexor retinaculum is the area where you have the carpal tunnel. And of course, the carpal tunnel is one of those areas where the nerve can become compressed, because on one side you've got bone, and on the other side you've got a sheath that keeps everything in place. And so anything that occupies that space or increases the pressure in that space can compress the median nerve. And when we look at the median nerve, the best place to look is actually the distal forearm, because the nerve is sitting between the superficial and deep flexor compartments. It's very easy to identify. And as you go more distally, the median nerve courses more superficially within the carpal tunnel, with the retinaculum here shown in red. Another important tunnel or canal is Guillaume's canal. This is where the ulnar nerve passes, and this is another place where a nerve can become entrapped, because on one side there's bone, and on 2 sides there is a retinaculum which can narrow the space there. And so anything within that area, such as a ganglion or a mass, can press on the ulnar nerve. So these are the conditions that we're going to look at when it comes to the hand and wrist: entrapment, neuropathies, trauma, inflammation, infection, and soft tissue masses. We'll start at the top and talk about these conditions. So carpal tunnel syndrome has got many different causes. And in fact, most of the time, as a musculoskeletal radiologist, I'm not asked to look at the carpal tunnel. It's very rare that a hand surgeon will say, oh, please do a scan of the carpal tunnel for me, because most patients don't have a space-occupying lesion in that carpal tunnel. Usually the nerve is swollen for many reasons, be it pregnancy or conditions such as diabetes, where there is no anatomical abnormality to see, and so the patient just needs a carpal tunnel release by the surgeon, and the surgeon's not worried about a tumor or a mass. So the times that we get asked to image the carpal tunnel are when we suspect that there is a space-occupying lesion within the carpal tunnel, which is rare. But there are many features that have been described in patients who do have carpal tunnel syndrome. And some people talk about flattening of the nerve as it enters the carpal tunnel. Some people talk about bowing of the palmar retinaculum, and others talk about a cross-sectional area of the nerve. And you can look longitudinally on the scan and see that as the nerve enters the region of the carpal tunnel, it becomes very narrow compared to outside. And that's a typical appearance in patients who have carpal tunnel syndrome or median nerve neuropathy. Again, another example here, where you can see at this point the nerve is very compressed and it's flatter before it enters the tunnel and also as it exits the carpal tunnel. So it's important that we're aware of the findings of a median neuropathy, but usually what we're looking for in cases of carpal tunnel syndrome is there an underlying cause such as a mass or a ganglion. This is a patient who's had tenosynovitis and an infection of the flexor tendon, and you can see how the median nerve is very swollen prior to entering the tunnel, and you can see how thickened the flexor tendons are. So this is a common cause of anatomical cause of carpal tunnel syndrome, so tenosynovitis. And this is a patient who has a ganglion within the carpal tunnel, which is causing problems with compression of the median nerve. Remember we spoke about Guillaume's canal. This is where the ulnar nerve passes just distal to the carpal tunnel. And you can see the Mickey Mouse appearance here is of the ulnar artery with the veins on either side, but it looks like Mickey Mouse. If you press too hard, you'll lose the ears. And there are many reasons to have a compression in Guillaume's canal. It may be a ganglion, it may be an accessory muscle, lipoma. You can get aneurysms of the ulnar artery in this region, and it may be that it becomes tight following fracture. And this is an example of a ganglion, and you can see the patient has typical features of an ulnar neuropathy with a claw hand and some muscle wasting. And this is a patient, that's the Guillaume's canal on CT. There it is on ultrasound, again, just using the comparative imaging to orientate yourself. There's the ulnar artery, and there's a ganglion that's sitting within Guillaume's canal. Moving on to trauma, we can use ultrasound in many circumstances to evaluate trauma. One is to look for foreign bodies, such as a thorn. Often the clinicians will think they've removed the foreign body, and yet the patient continues to have symptoms. And so rather than explore surgically, what they do is they ask us to perform an ultrasound to see if there's a reason for them to do further surgery. We can also use ultrasound to look for tendon rupture, to look for annular pulley rupture, gamekeeper's thumb, and also to evaluate some fractures. So we can see that ultrasound is very good for detecting foreign bodies. down to sub-millimeter size. And generally, foreign bodies are hyperechoic with an acoustic shadow, sometimes with some artifact. And you can see here that's a typical appearance of a linear foreign body or a thorn or a splinter. It looks echogenic, it's very straight, and there is some posterior acoustic shadowing. If there's a metallic foreign body, you may have a lot of posterior acoustic shadowing. And when you've had a foreign body long enough, your body will try, particularly if it's organic, your body will try to get rid of it somehow. And one way is by producing a foreign body granuloma which surrounds the foreign body. And you can see here this mass with a linear structure in the middle of it. And often when you see a foreign body like this, you will see a lot of vascularity of Doppler interrogation around the foreign body. We're moving on now to look at the tendons. And the flexor tendons are quite complicated anatomy. What you have is the flexor superficialis, which divides into two tendons that insert onto the middle phalanx. And running through the middle of that, you have the flexor digitorum profundus. So, in effect, at certain points, when you're scanning the fingers in cross-section, it looks as if there are three tendons that are there. Your profunda tendon surrounded by two superficialis tendons. And of course, these are kept in place by these structures, which are described as the annular pulleys. So you have several annular pulleys. You have A1, A2, A3 down here, and so on. And these annular pulleys can also become disrupted. And if they are disrupted, what happens is that the flexor tendon isn't held in place adjacent to the bone. The extensor tendons can be very difficult to see. Again, the anatomy, just to remind you, there is a central slit portion that inserts onto the base of the middle phalanx. Very important when we're thinking of how we report x-rays in the context of trauma. So on the extensor side, you can get these central slit avulsion injuries. And then you've got the tendon that then continues to the tip, to the base of the distal phalanx. With tendon rupture, ultrasound is very useful because it can confirm the abnormality, but as well as that, we can then mark the patient's skin so that the surgeon knows where they need to make their incision. If you do that, that may save the patient having a big scar where the surgeon is looking for the ends of the tendon. So you can help the surgeon by putting a mark on the skin. And this is an example of a flexor tendon injury, and you can see there a gap, and you can mark both ends, and the patient will then go to surgery, not needing a big incision. This is another example of a tendon injury where the superficialis portion was damaged, but the profunda tendon was still intact. So you can see that there's only a partial tendon disruption here, and this patient had cut themselves with a knife. Extensor tendons, as I said, can be more difficult to evaluate, and one of the tricks that I use is to perform a dynamic evaluation with kind of flexion of the finger to see where the structure is moving, because you should normally see the tendon gliding over the superficial aspect of the bone. And you can see there's a small tear. If you have the opportunity as well, what you should do is compare with other fingers. So you can see there's the normal tendon of the fourth, overlying the fourth metacarpal, and there's the torn tendon overlying the fifth. A structure which we're occasionally asked to evaluate on the palmar aspect of the wrist is on the dorsal aspect of the wrist is the sagittal bands. And these are bands that are at the level of the knuckles. And if there is a disruption of the sagittal band, what happens is that the extensor tendon becomes displaced, and it's typically called boxer's knuckle because it occurs in people who do boxing. And what you see is a subluxation of the tendon to one side when they flex their finger. So often the patient will actually be able to reproduce this, but you can see here very nicely on ultrasound that there's definitely a disruption of the sagittal band on this side of the finger because you can see the tendon subluxing over the digit. The annular pulleys, I said there are three main annular pulleys that keep the tendon in place, and most of the problems, if we do have annular pulley problems, arise in this region here, at the base of the finger, or in this region here, close to the metacarpophalangeal joint. Injuries in rock climbers and in rugby players due to kind of forced hyperextension can lead to injury to the A2 pulley. And the A3 pulleys are the ones where you have problems in patients who have trigger fingers, where their fingers get locked and the tendon is getting caught against the pulley. So this is a A2 pulley injury here. And in this patient, you can see here, it looks like tenosynovitis with fluid in the sheath of the tendon. But what you notice is that beneath the tendon is actually lifted up from the bone. In normality, in this position here, the tendon will lie against the bone. So if you look at this patient here, against a normal finger, the difference you can see between someone who's got an annular pulley rupture and a normal sign. Again, another example here, the normal finger at the top. Normally the tendon in this portion over here is up against the bone, and you can see here it's lifted off because of annular pulley rupture. Gamekeeper's thumb is a condition described in skiers as well, and in the UK where we see a lot of skiers at this time of year, what happens is it's a forced abduction injury of the thumb, and what happens is it disrupts the collateral ligament on the ulnar aspect, and this structure over here that was separate, gliding over the top over here, is a very important structure because that is what we call the adductor aponeurosis. And what can happen is that you can have a disruption of the collateral ligament where the torn ligament then lies on top of the aponeurosis, as in this example over here. You can see in this situation, if it's just torn like this, the ligament can heal by itself. In this situation here, where the ligament is drawn back and lies on top of the aponeurosis, it's called a stellar lesion. And it's important that we identify that because in these patients, they are going to need surgery because what happens is that the ligament will never heal by secondary intention. So you can see here on MRI, a nice example of a stellar lesion. There's the adductor aponeurosis there. There's the ligament sitting on top of it. This is going to need surgery because it will never heal by itself. And you see a similar appearance on ultrasound. So what we have is what we call the yo-yo sign, where the ligament is pulled back. And we have this structure here, which is the adductor aponeurosis. And so that looks like a yo-yo. And this ball of tissue that we see lying proximally is a classic appearance of a stellar lesion. Yet another example here. This is one with dynamic maneuvers. There's the adductor aponeurosis, and there's the stellar lesion. For fractures, I would say rely on X-rays to make the diagnosis, but be aware that sometimes an ultrasound, particularly in ultrasound of the forefoot, so in the feet, with metatarsal stress fractures, you will often see a fracture line and the callus formation around it. So ultrasound can detect fractures, but don't rely on it for detecting fractures. Always use X-rays. Again, just a couple of examples of fractures here seen on ultrasound. We're moving on now to inflammation, and we'll talk about some kind of repetitive strain injuries and also inflammatory conditions such as rheumatoid. So one of the commonest reasons that we'll be asked to perform ultrasound of the hand and wrist is to look for tenosynovitis or inflammation of the tendons. And what we'll see is fluid surrounding the tendons with thickening of the lining of the tendon. We may see loss of the normal fibrillar pattern of the tendon. And it may be that there is increased vascularity on Doppler interrogation. One thing we must remember is that not all tendon inflammation is just due to inflammatory causes or overuse injury. It may be that we are seeing tenosynovitis because of infection. So TB, for example, will give you a very marked tenosynovitis without the classic features of infection that we expect. And so just remember that infection is an important differential. We saw an example of this in one of the doctors who came for the hands-on session a couple of days ago. She had very good de Quervain's tenosynovitis, and this affects extensor compartment 1. These are the two tendons here are APL and EPB. And what we see is a thickened tendon with some surrounding inflammation on MRI. But we can see the same thing on ultrasound very nicely. So again, I've compared the abnormal side with the good side. You can see a very thickened tendon there, nice flat tendon on the opposite side. Again, longitudinally, thickened tendon, thin normal tendon. And there may or may not be increased vascularity around the tendon. The diagnosis of synovitis or joint inflammation is of huge importance to rheumatologists because these days we now have disease-modifying drugs which are very good at decreasing inflammation and preventing permanent joint damage, particularly in conditions such as rheumatoid arthritis. The thing is, these drugs are extremely expensive, costing many thousands of dollars or millions of dong. And it's important that we know that a patient, first of all, has got true inflammation, and as well as that, that it's responding when they're being treated. And so the use of Doppler is very important. This is a longitudinal view of the wrist, and you can see increased vascularity with synovial thickening in a patient with rheumatoid arthritis. I've spoken a little bit about infection already. Ultrasound is very good for allowing us to see if there is fluid that we can aspirate or biopsy. You can see sometimes that we can make out that there is osteomyelitis. This patient on the left side has a focal area of abnormality in the periosteum with a small sequestrum compared to the normal side. And there's increased vascularity on Doppler. And then finally, I'm going to talk about some common masses or lumps that we will see in the hand and wrist. Many years ago, I wrote a paper looking at the MRI features of lumps in the hand and wrist. And we know that most tumors that we see are benign, so they're not malignant tumors. And the commonest lump in the hand and wrist is a ganglion. We can use the distribution of the lump to help us make the diagnosis. In the fingers, a ganglion is the commonest lump that we'll see. This is a cyst that lacks a true synovial lining, much more common in women. Usually it occurs at the dorsum of the wrist, and there is continuity with the scapulunate ligament. Again, that's the longitudinal view showing the capitate, the lunate. And of course there's increased through transmission. And this is the transverse view. You can see that it's in contact with the scapulunate ligament. This is the commonest cause of a solid lump in the hand. It's called a giant cell tumor of the tendon sheath. Sometimes it's described as pigmented filonodular synovitis. And this represents a locally aggressive lesion that will normally need to be excised. And so if you see a solid lump in the fingers, usually it is a giant cell tumor of the tendon sheath, and usually it arises from the sheath of the tendon. Malignant masses are very rare. This is an example of a synovial sarcoma. It's a non-specific appearance. Sometimes you'll have a small lump that has a little tail associated with this, and this is typical for a neuroma or a nerve sheath tumor. And then finally, we have glomus tumors. These are tumors that arise from the neuromyoarterial glomus. That is a structure which helps us maintain the temperature in our fingertips. And these patients will end up with a small lump that has got increased vascularity, and they have excruciating pain from this, and often it will change according to the temperature. So when patients go into a different room or a room with air conditioning, they'll suddenly feel this pain. Or sometimes they'll just brush their fingertip and they'll have a lot of pain. And so the history is very important in these patients. And typically what we see is a highly vascular lump on ultrasound. So just to summarize, we've spoken about entrapment neuropathies, we spoke about the use of ultrasound in carpal tunnel syndrome. As I said, for fractures, use X-ray rather than ultrasound. But it can be useful for looking at injuries of the tendons and the ligaments. We spoke a bit about the use of ultrasound in inflammatory conditions and its importance to the rheumatologist. In the context of infection, ultrasound is very useful because it will allow us to guide aspiration or biopsy. And then finally, we've spoken about the use of ultrasound for the evaluation of masses in the hand and wrist. Thank you for your attention.
Thank you, Professor Siêu. Would you continue? Would you continue? Yes. Giáo sư Siêu tiếp tục bài tới là bài siêu âm khớp cổ chân, ultrasound of angle. Please continue. Would you continue? Yes.